to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Rate and review the show at kevinmd.com/rate. Subscribe at kevinmd.com/follow. Today, we welcome back on the show Paul Pender. He is an ophthalmologist, and now he's working in industry. He's been on multiple times on the show, so feel free to search back and listen to his fantastic past episodes. His latest Kevin MD article is The Dichotomy of Patient Needs and Patient Wants. Paul, welcome back.
Hey, thanks for having me back again, Kevin.
So we'll get straight into this article. Tell my audience what it's about and the story behind writing it.
Okay, well, I found that while I was practicing ophthalmology that oftentimes patients who had blurred vision came to me and sought answers. And so when you have to educate the patient, if they haven't gone to medical school or have advanced degrees, may not understand what a cataract really was. So I had to go through a description of what was causing their problem. And then I wanted to demonstrate exactly where the lens was, and I held up a plastic eye model, and I went through various teaching aids so that the patient would appreciate what the nature of their problem was and then what I plan to do to fix it. So the reason why there's a dichotomy is because, as you well know, patients may feel like they want to get this information or you want them to have the information, but what they really need oftentimes is reassurance. Mm-hmm. So I think I wrote the article because I felt like in today's healthcare climate, you are now facing asynchronous learning. Mm-hmm. Patients are sent to a website. They're trying to essentially automate an educational process, and it's not easy because when the patient watches this particular information plug for your practice, if you will, it's hard to know if they've retained it. Mm-hmm. And if you are sitting there in an exam room and going through this and you're looking at their face and you can see that there's either anxiety or they don't understand what you're trying to say, then you can kind of go back and pick up the pieces and start over or do what you have to do. So, it was funny because my scribe had heard this monologue from me so many times, she could probably repeat it word for word. Mm-hmm. And I realized that, well, okay, I suppose I could have just, given the patient my usual spiel about risks and benefits and sent them off to watch a standardized information video, but I just didn't feel that was going to be adequate. Mm-hmm. And I found that if I added a personal touch and if I did have this exchange with the patient, if I did spend the time to answer their questions, then I felt like I was doing my job, that the patient would be reassured, that they'd feel like I was the right person for the job, and that I was going to do whatever it took to make this turn out well. So the dichotomy is the patient may have certain needs to understand their situation, but they really want more than that. They want to feel like the doctor's in their corner, that the doctor is ready to exercise whatever professional judgment that has to be done in order to come up with a good result.
So take us into the exam room. So you're an ophthalmologist, so I'm sure you've dealt with hundreds, if not thousands, of people coming in for potential cataract surgery. So tell us a little bit about that interaction. What kind of questions do they ask, and how long in general would that interaction take?
Okay, so the exam part might be relatively short, 10, 15 minutes. The explanation might take it at least as long. But I think that it was funny, there are certain types of patients and the personality. Mm-hmm. Doc, just do it. Don't tell me what's going to be involved. Just do it. You have my permission. I just trust your judgment. Just do it. And I sort of felt like that patient still needed to understand what they were getting into. So I remember this one gentleman, and I was trying to describe how giving a local block, injection, not in the eye itself, but below the lid, was going to numb his eye because I really had to have ultimate control over the situation, which was different than my usual approach with just topical anesthetic. But having to give this injection below the eyelid, I started to go into detail. And he said, "Doc, I have a high tolerance for pain. I attended parochial schools. So I thought, okay, then you just trust me to do this, right? Yeah, okay, fine. All right. But in general, I've sort of felt like the way that patient education is going about now for certain conditions, whether it's surgery or something else, is that often they'll use cartoons to get a point across.
Mm-hmm.
But really, the patient wants to hear the physician's voice. The patient wants to interact with the physician, ask questions. And I think ultimately they have to come away feeling like, okay, I trust this person and I'm ready to go through this indicated surgery. So one of the points that I make in my article is that, it's been well researched that patients afterwards or before they actually going to undergo their surgery probably remember less than half
Mm-hmm.
of what the surgeon told them ahead of time. And so the aphorism that I quote in the article is, they may not remember what you said, but they remember the way you made them feel.
Mm-hmm.
And that is important. And giving that patient a feeling of confidence, of that you've made this connection with the patient so that that's going to serve you well in the future. That's a really important part. And so the dichotomy may be even more exaggerated these days with healthcare going to a lot of virtual training and learning. But I really think that personal touch is very important.
I completely agree with you. I think that the scenario that you describe, I face it a lot in primary care, whether it's a difficult diagnosis or a procedure they're about to undergo. I think that there's a lot of tension, certainly, with what you're proposing with the current reality of our healthcare system that's based on volume, that's based on quantity, that's based on less time for each patient. So, how can we give that personal touch to patients, which inevitably takes time, in our current healthcare setting,
Right.
which really focuses on volume?
Yeah, I understand that. And time is so precious because often patients feel like they're not getting enough time from the doctor.
Mm-hmm.
Okay. And I'm going to flip it back to you for just a minute because in your primary care practice, you have patients who come in with, print offs from their Google feed about what they think their condition is. And can't you just write me a prescription, doc, for this?
Mm-hmm.
And so, you know, their time is important as well. And so there are pressures to abbreviate that entire encounter instead of trying to expand it to actually answer the questions. And sometimes I think it requires being able to set aside our maybe professional egos to say, but did you consider this? Or
Mm-hmm.
that's an interesting point, and I'm sure that a lot of people experience that. However, you have an unusual case, or you bring it back to them and say, because this isn't a general approach to things, I'm recommending something for you specifically.
Mm-hmm.
And in that case, I think the patient and everything should just kind of grind to a halt. Okay, so what is it that you're recommending to me, doctor? Because maybe all this has just been a lead up to what they want to hear you say anyway.
Mm-hmm.
And I think that under a time crunch, there may come a point where the exam is shortened to what the essentials are, and then the discussion has to take place afterwards that's going to be more meaningful. But I also think that perhaps reinforcement can come if after the doctor encounter, there's some follow-up, there's something to close the loop. It might be someone in the practice. It could
Mm-hmm.
be even a medical student who's been mentored by the doctor who picks up the phone and says, do you have any questions after your visit? And how might we be able to address those questions now? Things that you may not have thought about before. So I think there are ways to create touch points. And I think that part of what we hope can develop is kind of a program by which our professionals that we are using as intermediaries and as patient advocates
Mm-hmm.
can actually provide some more of those touch points in the personal care.
Now, what's the role of technology here? Because we do have so many different ways where we can asynchronously connect with patients, like you mentioned, there's like videos, cartoons, and we normally send them away, and they can watch things on
Right.
YouTube and whatnot. So tell me the role of technology. Can technology supplement some of these touch points that you're talking about and give a little bit more of that personal touch?
I think it can. I think, the bulk of my practice was in the era of handing out brochures after the patient was sent back home, and then they would review things that were printed material. I think nowadays people have access to patient portals. They can ask questions that are done asynchronously, and the doctor can be maybe between patients come back and answer some things. It gets to be added pressure on the doctor for sure. And this has all occurred really since I retired 3 years ago. And I find that when I'm reading some of the essays that are on your platform, doctors are now inundated by a lot of these peripheral questions and things that take up their time that are often given free. Okay. So there's got to be some happy medium between a doctor being able to address questions in a timely fashion and for the patients to feel like they're not constantly on hold. You know what I'm saying?
Sure.
So I think there has to be respect for time, both the doctor's time and the patient's time. And I think the more that patients can learn about a condition beforehand, that's really kind of under the control of the doctor. I kind of favor that. So what our academy has done has been to provide patient portals, if you will, or the access to their website that is to address generalized questions, whether it be cataract, glaucoma, what have you, macular degeneration. So these are ways for patients to learn about something beforehand and maybe even to follow up after their visit.
We're talking to Paul Pender. He's an ophthalmologist, and he wrote the Kevin MD article, The Dichotomy of Patient Needs and Patient Wants. Paul, I'm going to ask you again to take us back into your exam room. What are some specific things that you've said, specific questions that you've asked that really reassured patients and really gave them that personal touch? Because a lot of times we're in the exam room, sometimes we don't quite know what to say. So from your years of experience, what would you say is some of the best things that you've said?
I would maybe prioritize them in the way that you first have to address what may be an underlying fear. When people hear about you're going to do what to my eye, yes, you're going to remove the lens and replace it with a new one that works better and is clearer. So of course the fear of operating on someone's eyeball is paramount. And so they may have had their friend or their aunt or uncle or someone who's already been through this, and they feel like, oh, well, you survived it. Oh, it's a piece of cake. A lot of my patients would hear that, but say, okay, prove it to me. Show me that this is not as difficult as maybe their grandmother had gone through. And so they're carrying some of these fears that are unfounded. So you address some of those things. You say, no, it's not going to hurt. What do you mean it's not going to hurt? Well, it's because we happen to give you a type of anesthetic that kind of coats the eye so you don't feel me working. You may have some bright light and you may feel maybe a burning sensation. And I said, oh, and by the way, because the instruments that break up the cataract and rinse out the cloudy material, some of that might run off on your cheek. So you might feel a little bit of water on your cheek. So I tried to prepare them ahead of time to what they might expect when they were actually under the sheet, in the middle of their procedure. And I think, ultimately, I would say, I'm going to do whatever it takes to make this work out well for you. I put my hand on their shoulder and I'd say, this is going to work out well for you. I would tell them what the risks were. And I'd say, this is something that can occur in a very slow percentage of patients, but I think you're going to do just fine. And that was really the message that I gave the patient who's about to undergo this type of work.
And my final question, what are some of your take-home messages that you want to leave with the Kevin MD audience?
Well, I think, your viewers and your readers appreciate the perspective that that physicians and nurses and medical students have on their interaction with their patients. And my interaction with my patients, I felt, was part of the joy that I received as a professional. But I also realized that each person was different, and I tried to individualize, whether it was my presentation to them, and oftentimes it was based upon just their vocabulary and their level of education. So I would redefine how I was going to present something so that they would better understand it, or if they were very sophisticated, we could get into more of the details about the actual surgery itself. But really, it was to try to meet the patient on their level, what they needed in order for me to feel like I've done my job educating them, and then to give them the confidence that they had to go forward.
Paul, thank you so much for sharing your time and insight. And thanks again for coming back on the show.
Kevin, thank you so much for having me back.